Healthcare Collaborative webinar series. My name is Cynthia Bolar, and I'm the co-chair of the PCPCC Education and Training Task Force. I'd like to begin with a couple of announcements. First of all, PCPCC's next webinar, Easing the Transition, Core Principles and Values for Building Effective Care Teams, will be held on Thursday, February 28th at 12 o'clock. And please register on the PCPCC website. PCPCC is also sponsoring the 5th National Medical Home Summit, which is going to be held March 13th to 15th in Philadelphia. You can also register for this very important event on the PCPCC net website. Today's webinar is sponsored by the PCPCC Task Force on Education and Training. Its title is Lessons from the Field, Building a Medical Home Residency Training Program for Medicine Departments and Health Centers. PCPCC is well aware that we will not achieve our goals for patient-centered collaborative care unless we have a workforce trained in the competencies required for this team-based model. We have already mounted an initiative to identify training opportunities for all the professions involved, and should you know of any, we would like to invite you to visit the PCPCC website and enter the information about your particular program. It is a simple process, but very important to our understanding of our workforce development capacity. There are also plans for a publication that will highlight some illustrative training programs. So please spread the word about this opportunity to register this information and participate in this effort. I also want to remind participants that during our webinar today, you can submit questions at any time using the drop-down box in the right-hand control panel. The questions will be held until the end of the presentation, and if we do not get to all of them, we will post responses on the website in the future, along with an archived webinar. In fact, that will be posted within 24 hours of this event. So let us proceed now with today's program. I am really so pleased to be able to introduce Dr. William Warning, Program Director at Crozier Keystone Family Medicine, and he is also my co-chair of the Education and Training Task Force. Dr. Warning will discuss key components of the Pennsylvania Academy of Family Physicians Patient-Centered Medical Home Collaborative. It is the country's largest program dedicated to bringing together family and internal medicine departments and community health centers to achieve medical home recognition, practice transformation, and improve patient health outcomes. Welcome, Dr. Warning.
Thank you very much, Cynthia, and welcome everyone, and thank you for spending Valentine's lunch with us. We appreciate that. I am calling you from outside of Philadelphia, Pennsylvania, and I am here to talk about our experience that we've had in Pennsylvania with building a large educational collaborative. The first thing I'd like to go through is the learning objectives for today. Certainly, we want to talk about what is the collaborative, what has happened in Pennsylvania to align these family medicine and community health centers, as well as giving you some tips that you can hopefully build your own as well, so that our goal is to really give you some transformation tips so that you can actually spread this. I'm getting back to here we go. So our goal is to really help you replicate, depending on where you're from, in different educational programs and non-educational programs to see if we can actually spread this to multiple settings. So first of all, what happened in Pennsylvania to align this? Well, Pennsylvania became part of the IPIP National Data Reporting, which is Improving Performance in Practice, which goes across about 7 states in the country and was getting some quality data and reporting it nationally. And then importantly, Pennsylvania got together and made a primary care coalition, which frankly was developed to address workforce issues, which most of our states in the country are looking at that closely now. And it was led by the Pennsylvania Academy of Family Physicians, but also the Pediatric Academy, as well as Internal Medicine, with a very strong partnership with the community health centers in Pennsylvania as well, again, operated from the Pennsylvania Academy of Family Physicians. So we had this coalition in place when the big thing happened. In 2008, our governor at that time put Pennsylvania into a chronic care initiative led by a multi-payer demonstration project. So this was a medical home multi-payer demonstration project which rolled out the same year that NCQA was starting their certification process in medical homes in 2008. The goals were to transform primary care practices as well as using the chronic care model to reduce costs for chronic diseases. Our governor was the convener, and it persuaded all the insurance companies in our state to get together to do this. It spread out over 200 practices in the state, over 2 million patients in a registry, and then became part of the CMS multi-payer advanced primary care practice for 3 more years. So the first one went for 3 years, and now we're 3 more years with the CMS project. And there was no delineation for academic or private practices. As a matter of fact, it was focused on private practices, 3- and 4-person practices, with the idea is this is a sustainable model, the medical home model across family medicine, internal medicine, and pediatrics in the state of Pennsylvania that can be used to certainly improve outcomes and decrease costs. And then out of that, we had some great experience in the state of Pennsylvania, and we said, you know, we have 30 family medicine residency programs in the state of Pennsylvania. Wouldn't it be great to teach those training programs to train the next workforce in the medical home principles? So we took 4 successful faculty from some of the practices that had some experience. We got them together and we said, can we get funding to actually lead an educational collaborative with the same idea to improve outcomes, chronic care model, and reduce costs? And we chose a faculty-led collaborative. I will get to this in a couple more slides, but we did not do the practice coach model, which I know a lot of collaborators across the country are doing. We've modeled a lot of what we did after what Colorado was doing, and I3 in the southern states were working as well. And we really wanted to focus on the academic practices, which are, again, somewhat unique, somewhat challenging. And then we became the single largest collaborative of its kind in the country. We did get funding from the Department of Health, from pharmaceutical companies, with a heavy emphasis on the chronic care model, and we offered a full range of services. Data services are very important. We got a lot of experience in the chronic care initiative in Pennsylvania with mastering data and reporting it out, and we added the educational process as well as a lot of support from the faculty and staff. We focus on safety net providers. As we all know, our residency programs and all of our training programs, medicine and non-medical training programs, are safety net programs. The patients we see in our practices are generally patients that are underserved or certainly have either no insurance as well. And we grew to over 19,000 patients in our registry in just the practices across the state. We started with family medicine and internal medicine programs and then added community health centers. In 2010, when we started with family medicine residency programs and 1 primary care internal medicine program. And our idea at that time was we had a lot of interest. We wanted to get all the family medicine programs excited about this and interested. Some of them for legitimate reasons. They were implementing EMR. They had a lot of other things going on they could not start with. The internal medicine programs got very excited about what we were doing. We do have several primary care internal medicine programs in the state and really wanted to join as well. We talked to pediatrics. I'll address pediatrics right now, is that we have 8 pediatric residencies in the state. We did talk to them about being in the collaborative. They have different needs, and they certainly have, even what we saw in the state of Pennsylvania, the pediatric groups started to actually develop their own collaborative. So they actually separated off into somewhat of a separate collaborative. So we did not have pediatrics at that time. And then a year later, we said, okay, we're going to start another wave of teams, including mostly internal medicine residencies. And what actually happened is we got the couple remaining family medicine programs, and then we had a tremendous interest from the community health centers. This somewhat shocked us. We had a great collaboration with community health centers, but they were very interested in becoming medical homes and doing this as well. So we really only had 1 other internal medicine residency come into the program at that time. And then we needed to change things. So about a year into that, we said, you know, there's different, and this is advice that hopefully all of you can take, there's different needs for training programs in a very general sense and practices, private practices, including community health centers. Training programs have a lot of educational needs and desires. Certainly the community health centers have a lot of federal reporting needs. So we actually broke the groups into 2 separate groups. So the way we look right now is that we have one large group of family medicine programs with 27 participating teams. We have a second group of just community health centers with 21 participating teams. Now, some of those community health centers do educate. They do have tracks of residents and students coming through, but we broke it into kind of residency program and community health center collaboratives. We really don't have a lot of interest with the internal medicine programs now because primary care internal medicine is difficult to get into these collaboratives and sustain, and the couple that were in there actually launched into collaboratives with their own organizations. This was solely sponsored by the Pennsylvania Improving Performance and Practice and together with the Pennsylvania Association of Community Health Centers. And what did the participants see? Well, first of all, we provide really the IHI learning community framework. So we have 3 one-day learning sessions. We house them in different parts of our state, so we can be anywhere from Pittsburgh to Philadelphia up to the north part of Pennsylvania. And we do that purposely because of our practices are all over the state. We just want to move it around. We actually buddy up with meetings from the Pennsylvania Academy. So they have meetings, and we use their venues when they have educational meetings, and we usually tack a day on for the educational collaborative, which is great cross-fertilization with the Academy and other members as well. We also have monthly webinars. So every month there are webinars for both groups, one for the Residency Program Collaborative and one for the Community Health Center Collaborative. And then we schedule phone calls and emails. We do ask the teams to do a couple musts. They must submit data. Data is tremendously important for these collaboratives. So we wanted them to submit data, and I'll show you how they enter that data in a monthly fashion. And they must apply for NCQA recognition. We used NCQA as the litmus test. We know there's other accrediting bodies out there, but at the time there really weren't. We said that everyone should submit to the highest level that they feel that they can achieve for NCQA. What do the faculty and staff do behind the scenes? We develop the curriculum, the timelines, and we plan the learning sessions. But we also oversee the team. So we're looking at the monthly data that they're supporting and giving them feedback, customized to that team. We know the teams. We know what they're going through. We know that they just had an EMR implementation or a couple faculty leave, or they, God forbid, have a site visit coming up. So we know that things can be lagging and they can have different energy. We also know the educational academic cycle. We just came through a recruitment season. We're going to go into a graduation season, etc. We also plan and lead monthly conference calls. We answer a lot of emails excuse me, from our teams, and then we update the collaborative website. And then the other things that faculty do is really the strategic planning, really looking for the future, fundraising, financial management. We do ourselves as a faculty biweekly conference calls with emails as well. And then an important part is what we're doing today. We're disseminating this. We have done this for now 3 years in this collaborative, and we've certainly been involved in medical home collaboratives now for almost 5 years. And we've presented to IHI twice. We have certainly presented to PCPCC, STFM, and multiple other presentations. Where does the funding come from and where does it go? Well, first of all, as I said, it came from our Department of Health and pharmaceutical companies. We pay the faculty a monthly stipend. So this is an important part for us to have. All of us have full-time jobs, and we really wanted to give the faculty time to buy their time from their institutions or have time in addition to what they're doing to allow for this. So some of the faculty will buy time from their institutions. They feel it's important for them to support this. And we wanted real-world faculty. We really wanted people who could say this sentence. In our practice, when we had this problem, we overcame it in this way. You know, this is what our residents were able to do. This is what our staff were able to do. This is what our attendings were able to do. And it was really helpful to have people who have been there. I won't say done that because it makes it sound like we've mastered it. Everyone's doing at the same time. All of us on this phone call are still doing this in a big way. So we're doing this together, but we certainly come over some of the hurdles that people are facing. And then we salary staff. The staff are a core part of the collaborative. They are hired just to do the collaborative. We did not design it with practice coaches. A lot of the collaboratives that we looked at had practice coaches who would go out to the practices. They were high-level nurses or CRNPs who would be trained to go out and coach the practices along. A couple things. It's a big salary item that we did not have in the budget to actually have that FTE set up there, but also geographically, we're a big state like many of you, and we couldn't really have just 2 or 3 coaches cover the entire state. We also felt that the teams needed to do this work on their own. We're lucky in a sense that our residency programs do have some academic time. They do have lecture time. They have some time carved out, and that's the time when we really wanted the teams to focus this work on their own and make up their own teams, because coaches will eventually go away. What's in it for the practices? We don't pay them. This is a concern. The practices do not get any compensation for this. We try to compensate their travel for when they come to the collaboratives, and that's all dependent on grant funding, but we do not pay them. And all of them needed to get buy-in from their hospital administrators, from people that count costs very closely and say that this is a good thing. So what was really in it and how could they convince their administrators that this is a good thing is that we are the educators. In Pennsylvania, we are cranking out the future workforce in the primary care residency programs. We are training in the pharmacy schools and the medical assistant schools the next generation of people. So we are preparing the workforce. That had a lot of power. I know that sounds pretty pie in the sky sometimes, and we say, well, gee, but we know that there are huge workforce needs. It's been so identified in Pennsylvania, and we were able to say that we need to train physicians now for the future, and medical home was one of them. We knew that it would improve quality and care in the practices, and practices would get more quality measure money. So they will get more pay-for-performance money. They will get some patient-centered medical home incentives that some of the insurance companies were starting to get on board with paying. And recruitment for family medicine and certainly our other primary care specialties is key, and students really want to train in places with a medical home. The students are savvy. They hear that this is coming. They know that this is important and primary care is at the heart of this, and they wanted to be part of residency programs. Also, the credibility with the home institutions really helped. There were multiple ivory tower institutions in the state of Pennsylvania where the family medicine department was the one on the forefront for this. They were the first one to get certified. They were the first one to start doing some of the chronic care management, and that really helped some of their credibility in their home institutions. We do provide CME, and we also provide that really needed Part 4 certification from the American Board of Family Medicine, so that when our faculty are part of our collaborative, all of our residency program faculty will get credit for Part 4 because this is what IPIP provides for them. We know that it's high-quality training and education that we won't get anywhere else, and I think there's something really powerful about being around others who are doing this. If any of you are trying to get NCQA or another certification for medical home right now, you feel like you're in a silo, and you want to attend courses, you want to reach out to webinars, you really are hungry for information and what did you do that worked, and now we have a room of, our rooms are about 150 people each now, where we can actually say what worked for you, how are you trying to solve that. So this community part is really important, and I think that has really helped the teams feel like I can do this. We do require that the teams have at least 3 members on every team who come to the learning sessions and are on the monthly conference calls. We want the lead physician, who is usually the medical director of the practice, but not always. It can just be a really key physician in the practice. We want a second-year resident. The second-year resident is key because interns really don't have time and aren't interested in this. Third years would have one foot out the door. The second year is really key. And what we have asked and what we have seen is that people will keep that resident on for 2 years. So now our collaboratives mature enough where we have a second year and a third year almost in every team, and they're passing it down doing projects together. We wanted a clinical supervisor, some type of a clinical nurse, head MA, or whatever the practice would identify as a clinical supervisor. And then we would love to have the administrative supervisor, the practice manager, and have some type of an IT support. We do have teams that bring up to 8 to 10 people. Some bring 12. We have teams who bring a clinical pharmacist, a social worker, multiple residents, multiple other team members, which is really exciting to see. We want them to attend the 3 learning sessions per year, participate in the monthly conference calls, and report data. That is very important. And we track it. And again, we don't tell them we can't do anything if they can't. We try to understand it. We try to help them. We try to provide resources. And after the first run-in period of getting data and data integrity, we were able to get good quality data and track it over time. And then each of the teams are assigned to a faculty mentor who is in communication with them about their data, about their pitfalls, trying to help them through it. And then we do ask them to apply for the NCQA recognition. We started with myself as the chair of the collaborative. I have a co-chair and then 6 other faculty members. Again, we're all primary care physician in residency programs. We helped develop and deliver the education, we work with the learners, and then we certainly work with the data as well. The data systems are key, and we are just very lucky in the state of Pennsylvania to have some savvy people in the data realm who have built data processes for the entire state, for the original collaborative, and we get the data systems in a readable format, in a ready format, and certainly timely. The education stresses data integrity. As this is self-reporting, so if your denominator of diabetics is between 18 and 75 years old, and you say it's 200, it's 200. If it's 1,200, it's 1,200. You know, we really want to get this data integrity down. We do have an extranet where the teams can submit their data. We don't have complete capabilities for them to upload it directly from their EMR. That would be ideal, and we're looking into that. But it is a manual reporting process that they do monthly. And then we look at benchmarks, and we look at national HEDIS benchmarks, we look at NCQA benchmarks, and we look at our own collaborative benchmarks. And it's transparent. That is a big word. We actually felt that teams like to know where they are in the collaborative. We used to say, you're Team A, you're Team B, and we said, no, actually, we need to know where does Crozier stand versus University of Pennsylvania versus Thomas Jefferson University. And there's a little bit of competition, I can tell you, in the room where people don't like to be a little behind of their colleagues. They're all in their residency program, training programs. We know each other and respect each other very highly. However, you want to be on the top end of that curve. So we decided, and we told the collaborative and asked their permission to make it all transparent. So we show data at the learning sessions. They see where they stand compared to other teams. That causes for a lot of celebration, and that also causes for a lot of going back home and saying, guess who's ahead of us, and let's put our nose to the grindstone and see what we can do. If you don't measure it, you can't move it. The measuring is so key. So I'll just show you 2 screenshots of what we do. This is the data entry screen. We have developed, again, through an extranet where people can put their current value as asthmatic. So this is basically where they would enter the actual raw numbers produced through their electronic medical record and put in the counts of numbers from there, and then they see that their percentages, et cetera. And then when that data comes out, it looks like this. These graphs have been extremely popular in the programs. There's something about the visual graph versus just percentages and numbers and net values and deltas. It shows that this team did something. Somewhere in this month, they increased their blood pressure significantly, blood pressure management. So if they started an initiative here and they can see this rate of rise, that really helps. It also shows them for something like I guess it's in this one, hemoglobin A1C is less than 7. The blue is the practice, and the red is the 50th percentile. So they're at the 50th percentile, and here's the 90th. And this is where they have to get to, and they're on their way to getting there. So these visuals really help. And then as you see, the Pennsylvania Academy has really developed these great systems where they can email these run charts to the entire practice and say, here where we are, guys. We're going to prepare for the meeting this month, and we're going to talk about it. You can put in PDF files, et cetera, but the email part has really helped. So you can email it to the team who worked on that and say, great job, look what we did, this line is moving. And they can also see graphs of other practices and compare them as well. There are a lot of measures. These are the diabetic measures that we ask them to report on every month. And we have added a few. Some of these measures are what we would call process measures. They're just typical, get the blood work done, is it documented? And then some of these are control measures. Are you actually controlling the blood pressure and the hemoglobin A1C, et cetera? We have diabetic measures. We have intravascular disease measures. So we also have IVD measures where we actually look at blood pressure, lipids, aspirin, antithrombolytics as well. We actually just added a depression measure. So a year into it, we started looking at, first year looked at diabetes, which is a great adult disease to choose. Asthma is a great pediatric disease to choose for these collaboratives, and this is our state experience that we tried. The second thing we added was IVD. Then in year 3, we added depression because all of our teams were certified under 2008 NCQA guidelines. Now 2011 will require the behavioral piece as well. So we actually said we wanted to prepare them for the depression management as well. And again, we're looking ahead for them. They're saying, why depression? We're saying because we know what you're going to need to be doing again, because we've been through that as faculty. We're a couple years ahead of you. And they thank us. They say, thank you for making us do depression. When it comes to looking at 2011 standards, the word is thank you, and they look at that. And then we started some focused challenge. So let me just give you a brief summary of how these collaboratives generally turn out. And I'm giving you experience from Pennsylvania, from Colorado, from the I3 program. We have presented these are the 3 largest collaboratives in the country in the educational realm right now. We have done IHI presentations together, and we have common themes that have come through. Number 1 theme, if you run a collaborative and you have it done for 1 year, what you generally will get is certification for medical homeness. Usually, we're using NCQA. And I didn't feel like that was the outcome. I wanted people to get certified. We felt like it was a great litmus test. We felt that they should get certified. However, to just end the collaborative after that, we felt would be a failure. That wasn't our goals and objectives. So in the first year, we spent a lot of time on NCQA and getting that everyone certified. The second year is mostly what I would call process measures. These are the measures that are, do you have a mechanism in place to draw an hemoglobin A1C on every diabetic and know if there's a gap when this patient comes in? And so building reports and getting the process measures was a lot of what year 2 was, monofilaments and urine microalbumins and all the kind of process measures. But then year 3, in a very general sense, turns into what I would call the good work. This is what we all went into it for, the outcomes. I want to save blindness. I want to save amputations. I don't want people to be on kidney dialysis because I'm controlling their diabetes so well. And they're the things that lag. They are that's the hard work. The outcomes are what we all want, we all desire, and I'm not talking utilization outcomes. This is not a controlling ED and utilization cost collaborative, however we're looking at that now, but just medical outcomes. So this is where the good work really starts, and this is what a lot of the collaboratives have seen over the country. It takes a while to get there because now the information system is built, the teams are savvy, and we have adopted PDSAs, the Plan, Do, Study, Acts, the IHI model of just do small little processes of change, then roll it out and spread it to the entire thing. So in year 3, we said, our blood pressures have just been lagging. They're doing pretty well. People are checking them. We're getting good data integrity, which took a while to get people getting the right data in. But we just want to do a better job, and we should be doing this. And then we guilt ourselves in that we're educators. We should be doing even a better job than the nation. Why should we even accept 50th percentile? So we have that little kind of educator guilt that we can use periodically, and we use that trump card occasionally. So we said, let's do a blood pressure challenge. Let's focus the teams on just one thing for a short period of time and just see if we can move the needle a little bit. So we said, can each program get 20 more patients under control? So look at the blood pressures that should be under 130/80 at that time. Now I know it's changed a little bit to less than 130/8 in a 4-month period, and let's just everyone try to get 20 patients who are not at goal. And then the top teams achieving it would say we would get this big award, which we didn't know. We didn't tell them what it would be. We didn't even know what it would be at the time, but we said we will give a prize. We chose this time frame, which fit into our learning collaboratives, from a learning collaborative in June to a learning collaborative in November when we would announce it. We will have you do this. And then we broke the teams into denominator panels, though, because we have some teams who are big, gigantic. I mean, they have really big diabetic panel sizes. They have 30, 40 doctors in their practice. We have other teams that are smaller, even though their residency programs are maybe the separate site, which they only have 4 doctors working there and a couple of residents. So we didn't want to hold either team accountable for their denominator size. We said, let's put you into large, medium, and small, which we just really picked based on the teams in our collaborative. There wasn't a hard, fast rule for that. Then we said, let's try to get those patients at goal in the numerator each time, and we're going to start doing everything we do in the 4 months is going to be around this. So each month we looked at data, transparent. Everyone saw where they were. If the challenge were to end today, this is who would win. This is who would not win. And that promotes them, oh my gosh, what are you doing that you're getting such good numbers? We tried this, it didn't work. How can we help? Then we did monthly PDSA cycles. We actually had them write it down, submit it to us, and we reviewed it on monthly conference calls. And we found some amazing things that people were trying, very innovative things that was incredible. A lot of faculty initiative, a lot of resident teams got together and did it as well, and they started sharing their PDSAs with us. We had them write them down and share them. We talked about challenges and barriers. We shared ideas. We saved other teams from getting into the same barrier that we already experienced, and it generated just a lot of enthusiasm. it's easy to have the collaboratives and giving information, and teams are absorbing it and trying things, but this really gave everyone a really focused goal, and we said, if I want to prove to you that if you do PDSAs in a really concentrated way, which is what we all learned in this collaborative, is that it will change outcomes. It will change the things we're actually looking for. It's not going to change as quickly as you'd like, but we can do it. We can have a difference. We can also talk about all those patients who are non-compliant, don't take their medicines. We care for people who don't have insurance and don't speak the language. We could sit there too and we'll talk about that, but we can also make a difference if we just turn around and try this. So we challenged them. We challenged ourselves. We did not know what would happen, and this is what happened. 318 patients who were not in control before 4 months are now in control. We raised our entire percentage of the collaborative 6 percentile points. And then we said, well, that feels really good. I mean, 318 people now have better blood pressure control than before just on that effort. We tried to put it in economic terms. What would that mean based on statistics? Now, these are probably inflated in a very general sense, but these are the statistics that are out there, that if you decrease blood pressure, there'll be a 32% decrease in risk. It will save money in the millions of dollars, and stroke gives you multiple millions of dollars. So we may have saved over $30 million in just these 318 patients alone. That felt good. Everyone felt like, boy, we are in this together. We are really helping. Teams were learning from each other. There was no longer the I won, you lost. It was very much we all need to do this. This is the common goal for everybody. The other litmus test was NCQA. Out of the 21 teams who started in the collaborative in 2010, by June of 2012, we gave them about a year and a half. 85% of the teams achieved level 3. Every team achieved the level they wanted except for one. One tried for 3 and got 2. This was impressive. These were teams that didn't think they were level 3 practices. They felt like, well, we're still doing this. We're not doing this really well. And we showed them, you are a level 3 practice. You do have this capability. And that gave them recognition in their institutions. That certainly gave them, in some areas in Southeast PA where I am, it gave them money from insurance companies per member per month just for getting that. So these were incentives that kept the collaborative going. And then the collaborative learning model. When we got a lot of these programs in a room, I will be very honest with everyone on the phone. There are 30 family medicine residency programs in this state. There are about potentially 8 to 10 around me where I am in Philadelphia. If I were to use a word that started with C, I don't think I would use collaborative. I think I would use competition. I mean, we compete. We compete head-to-head. We compete head-to-head for medical students. We compete head-to-head for grant funding. We compete for faculty. We compete for the best of the best. And this turned our competition word into collaboration. These were teams that were now working together, really meeting each other for the first time, some of them in a big way, and actually saying we're all after a common goal, and that's patient outcomes, and that's a better workforce, and that's better training, and this is the multiplier effect that we have. So as the collaborative started, the faculty talked a lot. We did a lot of presentations. We talked to them. The 4 of us and 6 of us really did a lot of presentations. We focused, as I said, on NCQA in year 1. We focused on processes in year 2, and now the teams lead. It turned into the collaborative learning model. The teams give us the best practices. We identify a team in Pittsburgh who's doing amazing things with pharmacists. We have them present. Someone else is doing incredible things with group visits, so they present. So we do team presentations, and they enjoy presentations, and they promote themselves to their own institution. We just led the collaborative and presented to 150 people. This is what it would look like in a timeline. So we just spread out the year. Again, looking at the academic schedule very closely so we don't glitch anything. We have monthly conference calls, monthly data reporting, and this is basically what the teams kind of must do. We look at them in levels of what we call engagement. We want to know that they are on the conference calls. We want to know that they are involved in the conference calls and presenting. So we do have them. We take attendance. We make sure that they're involved. And then this is what a sample learning session might look like. So how do we spend that day? We're very lucky in the collaborative that we're big enough. We have the ability to invite. We invited Perry Dickinson from Colorado here. So Perry came in and gave us a whole talk about what they were seeing and what are the ingredients for practice transformation. And then we used Perry later on in the day to talk to just the educational programs. So we talked about curriculum here. So this was just for the educational programs. The community health center programs weren't building curriculum as much, but this was, what would the family medicine training curriculum look like with the medical home principles. And then we're starting to do a lot of breakout sessions. we don't use the word really clinical support staff. My impression is everyone in the office is clinical. However, when people come to the collaborative, sometimes they are the practice administrator, they're the front desk supervisor, and some of the things that we talk about for the outcomes piece is not applicable to them. So we actually have them in breakout sessions now for the kind of non-clinical support or non-providers, and this was a whole thing about how to engage patients. How can a staff member engage patients in a better way? So this is what a typical learning session would look like. It's a full day. It is one day. They usually come in the night before, and then we get them out, and they can usually travel home that day. So it's one overnight for the teams. And then the sample team agendas. So these are the monthly conference calls. Again, we focus on at least one presentation that we're talking about. This was during the blood pressure challenge time, so we actually showed the data in a transparent way. We did some root cause analysis. How can the teams actually look at, we said 10 patients who are in the practice who aren't controlled, and then let's look at 10 other patients who haven't had a blood pressure for a while and get them in because they might be controlled. So we actually did a root cause analysis on that, and then we talked about practice redesign interventions from some of our faculty as well. So what are the outcomes? Well, there are so many outcomes that we could measure. A lot of us want to know, just on the educational side, are our residents getting this? Are they actually going into practices and doing this when they graduate? Are they transforming the practices that they join? Is the multiplier and the spread happening? That's part of our heart, is to really know that we are making a difference. We don't have hard data on that, but we have a lot of anecdotal data now, and I will certainly talk about our graduates. We graduate 9 residents a year at Crozier, and they are, number one, highly sought after as family physician graduates, but number two, they're really highly sought after because they've worked in a level 3 medical home during their entire training. And people have actually asked them, can you come join us and set up us as a medical home? And the graduate kind of looks at them and says, I worked in one. I didn't set it up, but it was just kind of what we did. And, so they actually have that ability. So they feel like this is very, certainly very sought after in the community when they go look for jobs, as well as it's our heart to really multiply this as well. That would be an educational outcome. Clinical outcomes, we're looking at, do we manage blood pressure better, being in a learning collaborative than, say, we did before the collaborative? And then there's a lot of financial data. We are looking at some outcome data and utilization data. So we're looking at ERs and transitions of care, et cetera. We were lucky to get 2 evaluation processes going, one from Penn State University with Bob Gabay and his group to contract with us to do an independent analysis of our effectiveness at these interventions among the practices and among the residents. They're actually doing some focus visits in each group to talk about the team and the transformation that went into each of these practices. And then we were lucky to get a CDC evaluation, which the CDC decided that they would use us as one of 2 awardees nationwide to look at blood pressure control. And they said, is this collaborative learning model working for a lot of the things that the CDC is looking for? In this case, it's a 30-month intense evaluation, really looking at blood pressure management. The expected outcome is that can the CDC really comb out the ingredients of a collaborative like this that are successful and then disseminate them into other learning environments. And then the CDC used the sustainability word. And I will, since I probably have most educators on the phone or a lot of people in education in multiple levels, I will tell you that when the CDC asked me about sustainability, they said, Bill, we really have a hard time. When we fund people, we give them a couple $1 million. They do something for 3 to 4 years, and we go back at the end, and we say, so how are you going to sustain it? And the answer we always get, well, if you keep funding us, we can sustain it. Look at the great results we have. And everyone has great results, and everyone's proud of it. But the idea is not to keep funding them. I can't keep funding them as a CDC to keep those great results. And if we don't fund them, our fear and what we've seen is after 3 to 4 more years, people that were hired and teams that were built are now no longer. How are you planning on sustaining this? And my answer was, we are building the workforce to go out and do this. We are training. I have residents in my program who have never known an office that's not a medical home. They've never seen one. They've never worked in one. They're going to demand it when they go out. It's just like a resident who works in a place with electronic medical record. It is very hard for them to go join a practice who's on paper charts. They weren't used to it. So our sustainability is what I think is the heart of our educational programs. We have that multiplier effect. We have the ability to train the next workforce and sustain it. So that would be the answer for sustainability. So let's go for a few highlights. First of all, we are physician-led. We did have some experienced faculty, luckily. I mean, again, a couple years of experience makes you very experienced in this realm because it's still so new. We built an infrastructure. We used NCQA as the litmus test and used the chronic care model. We went after the community of practice approach, this collaborative learning process, which we really feel is the secret ingredient for what we're seeing right now. And we need a staff. We need a very strong, supportive staff. The PAFP is a large organization. We're very lucky in the state of Pennsylvania to have them. We can leverage their track record. We leverage their donors and funders' reputation, and they have credibility, certainly. And we decided for national reporting. We didn't want to report to each other. We want to say, how do we rate against? We can look at how do we rate against Colorado, North Carolina? How does Pennsylvania rate? How do residencies rate against community health centers? How do they rate against each other? We actually have that data right now. And then we do a lot of performance tracking. Are there challenges? There are. I mean, challenges are the normal challenges that we get distracted sometimes. A lot of our teams get distracted by the fire that's burning in their program at the time or what's happening clinically or flu season. These things are clinical responsibilities that distract you from doing, monthly reporting and doing blood pressure challenges. We are residency programs, so we do have that cycle that we have to look at, and we have lull times and times that we just don't really touch the teams very much. The administrators, we were very worried about buy-in from the administrators. And many teams struggle with this because, again, we're not funding them, so it actually costs money for them to come join this collaborative. I think getting that first level 3 certification really helped them go back to their administrators and say, this is what we got out of 3 or 4 learning sessions. Oh, what else are you getting? And now our residents are really excited to join projects, and now we're getting better quality points at home. We proved that a lot of teams are actually getting paid for this in a soft way in the sense that their QIPS programs or their quality or whatever you call the P4P in your area from insurance companies has actually gone up since they've done this work because they're actually able to track it and be a little higher level practice. Again, we don't supply financial incentives. The data reporting is a big one. It took a good 6 months. This is what we've seen across a lot of collaboratives to get really good, consistent reporting data. So if we're trying to do any trend analysis, we almost have to throw out, as Bob Gerbay's group's doing right now, throw out some of the time to say, okay, when you level up, this is the point we're going to use as the starting point. You have to be fluid in your curriculum. Things do change. We are very innovative. We're trying different things. We're listening to our participants about breakout sessions and who we're going to bring in. And the healthcare world's changing. As you know, I think it's changing favorably for us. I mean, I think medical home and chronic care initiative is going to be king. I certainly think that with everything changing right now, that it's really put us in a place like that. So in summary, this is a large collaborative. I think it can be developed and sustained through the momentum. We don't have a stopping point. People have asked us, are you going to be a 1-year or 3-year or 5-year? I said 3 to 5, but what we've seen with the outcomes building now, this is really the great work, and teams are actually growing. We have teams who are just coming with their 3 members, and let's meet the criteria, okay, and then now they're bringing 6, 7, 8 people. We're getting bigger rooms for the same amount of teams because they're seeing value. They're driving people across the state to come to this. So we're still growing and sustaining. I think you have to identify your goals and then worry about the details later. You can get bogged down in that. You do have to have some experience. I think peers really helps. Physicians who are doing this, just like the people that we're working with, really does help have some of that. And then leveraging technology. Everything should be asynchronous and up on the web if someone did miss something. You certainly need strong supportive staff. We're very lucky to have the Pennsylvania Academy as our backbone of our staff, and then be flexible as well. So I'd like to stop for any questions or comments anyone may have. We do have the online questions that you can type in, and Cynthia has been looking through them. Thank you.
Yes, thank you very much, Dr. Warning. I think this is a superb example of a program that's really helping to prepare our workforce for the 21st century of healthcare and how incredibly important that is. I know that the programs themselves are designed primarily for the training of the family practice and internal medicine residency programs, but you've also mentioned briefly that you have social workers and pharmacists, and I know you have psychologists on staff. And I wondered if you could comment a little bit on the opportunities that these collaboratives also provide for interprofessional training and training to work as teams with other disciplines in this kind of work.
Very good question. When we first started the Residency Training Collaborative, there was only 2 teams who actually had a clinical pharmacist working with them part-time. Now we have at least 10 teams. We probably have about 14 clinical pharmacists in the state of Pennsylvania working with collaboratives. So that just shows you that they saw that somebody else was doing it. Someone said, well, we just partner with our pharmacy school nearby, and people just really haven't thought of that. And the pharmacy schools love this. A lot of them have AmCare residencies and house residencies. So we have seen the pharmacy piece grow. We all know that we would love to have and need social workers in our practice. Sustaining that in a medical home is important. And when they started coming, we started making listserv for some of these other sectors so the pharmacists could connect and share information, because people didn't even have job descriptions in the beginning. So, well, what's your pharmacist doing? What would it look like if I even went to my administration? So we share some of that. Certainly behavioral health and behavioral science is huge in these collaboratives. We are lucky in family medicine that most of us at least have to have a part-time, if not a full-time, behavioral health as part of our faculty or in our office. So we came to the table with that, which is very different than the community health centers. They're really struggling with that. They're looking for ways to partner with agencies. But the collaborative, getting them together in the same room, helps people see another person in their job description who's doing it, and then they start building their own relationships. So again, it's really grown from a few people. It was mostly physicians in the beginning, now to multiple specialties and interprofessional.
And from our perspective, obviously, it's a great place to be training psychologists and other health professions in addition to the residencies. One of the comments that a person made online was the disappointment, as a pediatrician himself, that somehow pediatrics didn't come along in terms of that original effort that you made with internal medicine, and any hope that that might change in Pennsylvania?
We are talking to them. We have 8 pediatric residencies in the state, so we're lucky. We have a fair amount, actually, and they have to. They're getting together, and we're trying to see if we can support them with some of our certainly experience to start their own collaborative. In the chronic care initiative, there are several pediatric practices who are their own collaborative. They report on asthma mostly, and then a lot of preventative diseases as well now. So we do have some robust data in PA from pediatric practices. But we don't have the educational programs together in a collaborative yet.
Okay. Related to this, one of the questions had to do with why did pharma fund this initiative, and how did that happen? And also, what else has pharma done related to these kinds of issues for training? And can you suggest specific ways in which pharma can collaborate to enhance PCNH training?
That's a really good question. We got one of our initial big donations from pharma, and it was unrestricted, which is wonderful. It came in through the Academy Foundation, and so it was a very arm's length agreement, which was a concern for most of us. We are ivory tower educational facilities that have our own language about that, and we had approved our own institutions that this was not this was an arm's length agreement, which we have proven. I think that when you use patient outcomes, I mean, this is really what the PCC has proven. When you use patient outcomes as a single denominator, you get a lot of people around the table who are all friends. Pharma, insurance companies, patients, businesses, and certainly providers all want better patient outcomes. So that was, I think, the common denominator that got that. We do have teams that use pharma in ways that for support services, a lot of pharmaceutical companies will have educational modules that they can use and do some lunchtime training, and they use them more on the local level. We have not used that as a collaborative level. We're really liking the Department of Health funding, which is very aligned with our initiative as well, but again, all of our departments of health really don't have a lot of money. They're really looking for that grant as well.
Mm-hmm. And as you know, we've talked in the Education and Training Task Force about the problem of funding education and training for these endeavors. We know that we already have a shortage of GME positions for the number of medical students that are currently in the pipeline, and other health professions don't even have the kind of funding that GME provides for the medical profession. Certainly systems like the ZA and systems like Kaiser Permanente invest in their own training of the workforce so that they can prepare people to work within their systems. We've not seen that kind of investment by private insurers or private industry, and I think that is an open question that needs further exploration of how much should the private industries help invest in the education and training to develop the workforce that will help us get the better patient outcomes. So I just offer that as a little viewpoint of my own at this time, but I know that we've discussed it at various times in the training. Another question came up with respect to whether or not the slides for the one-day learning sessions would be available for others to use.
But that's a good question. They're housed on our intranet right now, so it is on the Pennsylvania Academy's intranet. We do have some curriculum that is built, and we've looked at others as well. So I don't think that would be a problem. It's specific to residency programs, so I think as long as people understood the objectives, but I would have to check through the Pennsylvania Academy. It's not on the web, though it is on intranet.
Mm-hmm. Another question was why you chose the NCQA measures for outcome rather than maybe others offered by other groups or URAC or.
Well, that's a good question. In 2008, our collaborative started with NCQA in Pennsylvania, and then we started in 2010. It was really the one that all of the faculty were comfortable and had certified. So it was really at the time we started. We have broadened that. We want people to get certified. So I don't think that we mandate per se which organization they get certified in. Everyone so far has chosen NCQA, however. There is an insurance company in Pennsylvania who uses NCQA as the certifying body to pay per member per month. So that is an initiative as well.
There was another question about, did you find that one of the faculty became the change agent to talk to physicians, for example, to transform to the PCMH? And did you find particular individuals that became more robust change agents than others? And it's the same at the business office level, whether there were some individuals who kind of took on that role to help transform.
That's a good question.
Quality care.
That's why I'm a program director, so I oversee the whole program, but I have a medical director who really oversees the practice. And I asked my colleagues, the program directors, I don't know if I want you guys and gals in the room. I want probably the person who's really running the practice in the room, because they're the ones who are really in the practice all the time and see everything, and they know how your staffing ratios, and they understand everything. So that really helped to get someone who's really grounded in the practice, number one, at the learning sessions. The second was to get the resident. There's nothing more powerful than a resident going back to their peers and saying, oh my gosh, what we just found, this is the coolest thing ever. We're in a room with everyone across Pennsylvania, and we're doing some amazing things. You guys want to join in and look what we can do. I tell the teams, if there is someone in your practice, and there always is, with their arms crossed, shaking their head, saying, this isn't going to work, and I'll give you 10 reasons why, my best advice is bring them to a learning session. Bring them along. Because when you get in this room with 150 people all fired up about what we're doing, it's really hard to leave there at least not a little bit convinced that maybe I should at least think about this. So it's really important to have someone who's bought into it, number one, and that's why it doesn't have to be the medical director. We've had some lead faculty with credibility at the institution. The program director chose that person because they were, excited about it. You want your lowest hanging fruit people who can get excited about it, who have credibility to go back. And then when the staff go back, I brought my head medical assistant in because she could go back and say, oh my gosh, everything Bill's been saying is actually true. I mean, this is amazing what they're doing. And so that, we all know that. I mean, when Cynthia comes and talks to my people, there's more credibility than when I go talk to your people. So it really helps to have those people in a room. And there's something about seeing everyone aligned in the same goals, that is transformative.
Oh, that's very useful, and certainly making use of that of what we know about the psychology of change in terms of getting kinds of things implemented. One other question was about you added depression, and they were wondering whether or not you thought that depression should be screened more often than just once a year.
Absolutely, yes, that was the minimum. That's where we wanted everyone, and I think that was meeting the criteria. So when anyone said, well, I just want to meet the NCQA criteria, we actually do it at every visit, and that's what a lot of teams have done once it gets in the workflow. And not just diabetics. I mean, you have to start somewhere, so we started with diabetics, then we rolled it out to the entire practice, mostly adult practice, but adult part of the practice. But yes, I definitely would agree. It has to be a minimum of once a year, which gives you the the credibility that you've done it and you have a process in place, but certainly we do it at every visit.
Great. Well, I think that's all the time we have for our questions right now, but we'll be able to post some responses to some of the others on the website. I do want to thank everyone for participating in this event. Remember, the webinar will be posted with the audio within 24 hours and some of the responses to questions perhaps later. And also want to wish everyone a happy Valentine's Day for you and your loved ones, and appreciate your commitment to the efforts that we're trying to make in education and training. Thank you very much.
Thank you.